Good morning. It's a true pleasure to be speaking to you today about Data2 and children with stroke. I want to start by thanking the Data2 Foundation as well as Chip Chambers for inviting me today. Today I'll be talking to you about how a person in a pediatric stroke practice sees kids with childhood stroke who have Data2 and how we think about it. As we have 2 or 3 kids in our practice who we've identified with Data2, I think this is a very important part of my practice and in other childhood stroke practices as well. Today, I'll start by talking to you a little bit about childhood stroke, how it presents and what it looks like. Then I'll be giving you a description of a Data2 case, the first case I ever saw, and then tell you a little bit about Data2 and stroke and how it influences our practice. So when we think about pediatric stroke, there are 3 common causes of a child to have stroke. One is to have a venous thrombosis, second is to have a hemorrhagic stroke, and the third is to have an arterial ischemic stroke. Traditionally, we thought mostly about Data2 being an arterial ischemic stroke with a few hemorrhagic components. However, one of the things I'll be talking to you about later is my concern that we may be missing some Data2 in kids with hemorrhagic stroke. Mostly today, though, I'll be talking to you about childhood arterial ischemic stroke, which is really, by definition, a child 1 month to 18 years of age who presents with an arterial ischemic stroke or a clot causing a lack of blood flow to a part of the brain and endoschemia. Some baseline data about the epidemiology of childhood stroke. About 1 to 2 kids per 100,000 per year will present with an arterial ischemic stroke. In my stroke center here in Colorado, we see about 20 to 30 a year. The number of kids who present with stroke is more predominantly male for reasons we don't know, at a median age of about 6 years. For about half the kids, or maybe a little less, we have an understanding of why they've had a stroke. Maybe they have cardiac disease and a clot that embolizes from their heart, a dissection of one of their blood vessels, sickle cell disease, which is a known cause of stroke. However, for about 2/3 of the cases, we don't totally understand why kids have stroke. And these are the kids where we have to think about Data2. About 3/4 of kids who have a stroke will leave the hospital with some sort of neurologic deficit, and up to about 10% will die. Kids with stroke present with similar signs and symptoms of adult stroke, with focal neurologic deficit presenting as face drooping, arm weakness, difficulty with speech, or headache. Most common stroke signs in kids will be the same as in adults, with arm face weakness or dysarthria. All told, about 4 out of 5 kids will present with the same fast signs as adults with stroke. When seeing a child with a focal neurologic deficit, we don't always think of stroke right away, although with increased education, people are thinking more and more about it. Many kids with focal neurologic deficit won't have a stroke. They'll have a seizure with a postictal Todd's paralysis, a complicated migraine that can mimic itself as a stroke, encephalitis, concussion, or a bleed. So an arterial ischemic stroke, usually in the bottom of our differential for kids with focal neurologic deficit, unlike adults where atherosclerotic disease causes them to be much more likely to have an ischemic stroke. When we identify a child with stroke, we usually put them into several different possible categories. This is a classification scheme that we put together in the International Pediatric Stroke Study about 8 years ago. And the first thing we might think about is small vessel disease, which is pretty rare in kids with stroke. Kids who have small little strokes that look like small vessel arteriopathy are very good candidates for to be thinking about inflammatory diseases such as Data2. Very commonly, we'll see a focal cerebral arteriopathy in a large vessel. I check these kids for Data2, although I will tell you that many of them end up being negative. We also see bilateral arteriopathies, which is moya-moya, which is less likely to be Data2 in my experience, dissections, cardioembolic disease, and sometimes multifactorial disease. Secondary classifications reveal that often there is genetic vasculopathy underlying their disease, which would overlap with Data2. Infectious causes, hematologic prothrombotic causes, or also genetic causes or drugs and toxins. One of the most common causes of childhood stroke that we don't completely understand are kids who have a focal cerebral arteriopathy. The reason I mention this is that I think that I've checked for many of these kids to have DADA2, and most of them have been negative. However, I think it's something that needs to be checked for in these kids. In these children, what we'll see is their distal ICA or proximal MCA will be narrow in a banding pattern or a regular pattern, and they will have a basal ganglia stroke. The treatment of childhood stroke is similar to adult stroke. We will consider TPA, but it's only given to about 2 to 3% of kids with stroke, and it's not necessarily the standard of care. And many centers will start antiplatelet therapy, and some will even start anticoagulation. In some centers, because of the high prevalence of dissection or cardioembolic stroke, we will start with anticoagulation, and then once those are ruled out, transition to antiplatelet therapy. And then secondary prevention would be with aspirin 2 to 5 milligrams per kilogram. I mention these treatments because they're very important to consider in DADA2 because of the risk of hemorrhage in DADA2. And if you don't make the appropriate diagnosis, you could actually cause harm in a patient with DADA2 if you were to give any of these therapies, which makes it all the more important to make this diagnosis. All right, now that I've given you a little bit of a background on childhood stroke, I'm going to tell you about a couple of DADA2 cases. So this is the first child I ever saw with DADA2. This is an 8-year-old boy who presented in 2009. He had a sudden onset of wiggly vision and noticed that he saw 2 TVs next to each other. He went to an ophthalmologist who noted right eye adduction defect, or his right eye was out, and he had some right eye ptosis, or that it was drooping a little bit. The eyelid was drooping a little bit. The first thing the ophthalmologist thought of was the possibility of myasthenia gravis, and actually did a test for that called an ice pack test, which was negative. When that was negative, they did an MRI in an outside hospital. This is a diffusion-weighted imaging technique that demonstrates a bright spot in the midbrain of this child, as well as a dark spot on ADC mapping. This is a little bit larger scan, but kind of blown up. And this demonstrates that there's ischemia in the small area causing these symptoms. The patient was transferred to my hospital, and we did a workup. A SED rate and CRP were normal. Sorry, a SED rate and LP were normal. However, CRP was mildly elevated, which can be a clue in DADA2. Thrombophilia evaluation was normal, echocardiogram was normal, and MR angiogram looking at the large vessels were normal. Family history suggested that multiple family members had a history of autoimmune disease. And our ultimate diagnosis was that this patient was thought to either have demyelinating disease, such as the beginning of multiple sclerosis, or some sort of stroke. We started the patient on aspirin 4 milligrams per kilogram per day, and set him up to follow up as outpatient. Now, as I'm going through this case, I'm going to tell you different clues that we identify for DADA2 in kids with stroke. I would say that first thing that I would set off alarm bells in my head now that I know, and we all know more about this disease, is that if you have multiple diagnoses that are considered that don't fit perfectly, that's when you might start thinking about this. So already this kid had been thought of as possibly having myasthenia gravis, clinically isolated syndrome, which is the beginning of multiple sclerosis, possibly stroke, maybe a small vessel stroke. So when that happens, I think you should be thinking DADA2. In addition, the elevated CRP was a clue, as was the family history. So we continued this child on aspirin, and then other systems started to become involved. In 2011, our patient began having abdominal pain and vomiting, nighttime fevers, and had some high blood pressure that was thought to be secondary to renal scarring. And then in 2012, developed a spell of right-sided facial numbness, and well as a rash, which was a non-blanching, lacy pattern purple rash on his extremities. He also began having intermittent knee and ankle pain without swelling or stiffness, and some Raynaud's phenomenon was noted. Now, at this point, there were even more clues that developed. He began having multi-system disease, another hallmark of DADA2, including rash, and as we all know, livedo reticularis is a clue to DADA2, as well as arthritic symptoms. He had recurrent fever, which is another clue, and then another big clue is my patients with recurrent neurologic symptoms. Although this was a TIA without a normal MRI, it was again another clue. So in 2013, he presented to our rheumatologist and was noted to have subcutaneous nodules in his fingers. They did a biopsy and diagnosed him with polyarteritis nodosum. He began immunosuppressive therapy, and our rheumatologist, as well as the mother of this child, identified that DADA2 might be a possibility. He went to the NIH and received the diagnosis. So the last clue was these subcutaneous finger nodules, which made them think of this diagnosis. So now he's a 19-year-old kid. He's been stable on Humira. He's been off aspirin because of the hemorrhagic stroke risk in kids with DADA2. He follows with the NIH, myself, and rheumatologist, and he's doing great. So after this child became part of our practice, I decided to implement screening tools for stroke in our kids with DADA2. And now I ask all kids about rash, high blood pressure, joint pains or swelling, nodules in their hands, fevers, or family history of autoimmune disease. And in addition, any child that has an idiopathic stroke that I see in follow-up, I will repeat a CRP and SED rate and send off plasma 88.2 activity level. So subsequent to this, I saw a second child who was a 15-year-old male who was previously diagnosed with a clinically isolated syndrome. He had an INO, or difficulty with how he moved his eyes, not being able to move one of them out. It's a fairly common diagnosis actually in demyelinating disease, and one that I've heard of and seen once myself in DADA2. At this point, his SED rate and CRP were elevated, and he was thought to have some sort of beginning of MS and was discharged, not on aspirin this time, but he returned with a right-sided weakness with ischemia in his left internal capsule. When I saw him, he had multiple DADA2 clues, including multiple diagnoses considered at this point, elevated inflammatory markers, and recurrent neurologic symptoms. We sent off his adenosine deaminase activity level, and it was positive. He also has gotten appropriate therapies and done great. So now, after telling you about a couple of DADA2 cases, as well as giving you some background, I'm going to tell you a little bit about DADA2 and some of the literature about stroke. So about half of kids with DADA2 will present with neurologic symptoms. Many of them with ischemic stroke or lacunar strokes, those are small little strokes. Many with cranial nerve palsies, which presented in both of our patients, and more rarely with some hemorrhagic stroke component. About 10% of kids will have a polyneuropathy. Case reports have demonstrated other findings, including spastic diplegia in kids with a spinal cord stroke, neurosensory hearing loss, labyrinthitis, encephalopathy, cerebral atrophy, aneurysms, which I'll tell you a little bit more about in a minute, and optic neuritis. So in any of these cases, you need to consider DADA2, but particularly the ischemic stroke cases I told you about, and increasingly, in my opinion, hemorrhagic stroke. So here is some of the imaging from the first ever case reports of DADA2 from the original New England Journal of Medicine article. You can see in panels D and E, small ischemic strokes that are either in the brainstem or in the deep gray matter. This is hyperintense on TWI imaging. Follow-up can show encephalopathy on T2 imaging. And this is an echo street sequence demonstrating that some of these children will bleed. A more recent article that's coming out in 2020 this year from Sharma et al. Followed 33 kids with DADA2 and has some findings that I want to share with you because I think they're important. In addition to what we know that many of these kids will present with ischemic stroke, as well as rarely with a hemorrhagic stroke or a mixed picture, she's found that some of these kids will actually have aneurysms. And indeed, here's a 14-year-old boy who presented with an intracranial aneurysm on a CTA here, which makes me wonder whether or not we should be screening more for DADA2 in kids with aneurysmal disease and or ischemic stroke. So in conclusion, I would like to reinforce the idea that diagnosing DADA2 in patients with a neurologic presentation can be life-saving. This is particularly true for two reasons. One, aspirin, TPA, anticoagulation, all of these can be harmful in kids with DADA2 as they might increase the propensity to have bleeding. And so identifying these patients and taking them off of anticoagulation or antiplatelet therapy is very important. In addition, allowing patients to start immunosuppressive therapy who have DADA2 is very important in their treatment regimen. And as you can see in my two patients, they often will do very well after that. I want to reiterate the clues to diagnosis for kids with DADA2. I think anytime you're seeing a kid with multiple neurologic complaints and multiple diagnoses are being considered, but none of them fit perfectly. Think about our kid who had the possibility of stroke, the possibility of multiple sclerosis, the possibility of a neuromuscular junction disease, such as myasthenia gravis. When you're in that situation, I think it makes sense to send off adenosine deaminase level. In cases where you see small vessel disease, lacunar strokes, particularly in the brainstem or in the deep gray matter, you should definitely test for DADA2. And in patients that have elevated CRP, SED rate, or CSF pleocytosis, you should consider the diagnosis, especially if it persists beyond the acute period. Obviously, a family history of autoimmune diseases, particularly a history of DADA2 type symptoms, is very concerning for possible DADA2. And then anybody who has multi-system disease, particularly presenting with arthritic system or levator reticularis, should be tested for DADA2. And then obviously recurrent neurologic symptoms or recurrent fever. So with that, I will take your questions. This is my thank you slide. Chip asked me not to linger on it, so I won't do so. Thank you very much. Again, thank you for the opportunity to share with you today. And I think sharing this with other neurologists is really important. I have presented this data a couple times to IPSS. And one of the things I think I've learned from my most recent literature search is that I think in addition to considering testing kids with ischemic stroke, I think increasingly it's important to consider kids with hemorrhagic stroke as well.